I'm just going to talk only the basics of nystagmus, nothing very advanced. I'm not going into the pathophysiology at all in detail. I'll be showing a few videos towards the end of my presentation. Dr. Paini, thank you very much for this opportunity, and I really enjoyed your talk. I'm waiting for Dr. Alim's. So I'm sandwiched between the two of you in this talk, and let me see how much justice I can do to it. We all know what's a nystagmus. It is defined as rhythmic, abnormal eye movements. Slow movement driving the eye off the target, followed by a second movement which brings it back to the target. So slowly, when you're seeing something, your eyes move slowly away and then it comes back. So that is known as a nystagmus. It commonly affects both the eyes. Occasionally, it can be present only in one eye. So when it occurs, it's like the INO. It can be lasting just for a few seconds, or it can be a permanent feature in some conditions. What is happening on my screen? Okay. So what do the symptoms present in these patients with nystagmus? They usually complain of whatever objects they are seeing is moving. That's their visual field is moving. This is otherwise known as jumpy vision or oscillopsia. Whatever you see seems to be like how my hand is shaking. And because of this, they may also complain of blurry vision. They may not be able to tell it's shaking. They may also say it is a blurry vision. And whenever it is related to the vestibular system, then you have other features of involvement such as hardness of hearing, tinnitus, etc. Which due to the central nervous system, then you can have diplopia, dysarthria, cerebral arthritis, etc., etc. Balance symptoms. Not all nystagmus are pathological. Some can be physiological, some can be pathological. When this is pathological, the causes can be from the eye itself, the vestibular. Then from the central nervous system, it can be cerebellar, brainstem, cortex, or any combination of these can be present. We should know how to differentiate a central nystagmus from a peripheral nystagmus. We'll look at it in the following slides. So how do you describe the nystagmus? It's very easy to remember: dwarf. Though it's a giant subject, this mnemonic dwarf sums it up. So you have to describe the direction of the nystagmus. W is for the waveform, A is for the amplitude of the nystagmus, reducing direction, as well as frequency direction. What direction is it? Is it horizontal, vertical, or whatever it is? Waveforms, which is the wave pendular, rotating, amplitude, which is slow, fast, and whichever side it's reducing in direction, frequency. So when compared to the direction of the eye movements, you classify it as horizontal. It moves from side to side. Vertical is, as the name indicates, I think up and down. Torsional is, it's got a rotatory component, or it can be combination of all the three also. Then you can also type it according to the speed. Though these eyes move rapidly and uncontrollably, they can have a slow component to one side, corrected by a corrected by a fast component, and this can occur in both the eyes, or it can be different in the two eyes. And this can be worse when looking in certain directions, can be better in certain other directions. So in addition, patient may feel it's better when they tilt or turn their head so that their vision is better. This is very important to find out during clinical examination. The waveforms have, as I've shown here, you have the slow phase and the fast phase. And you can see the slow pendular one, which there is no slow or fast phase, the bottom one. When it comes to the jerk, you have the slow or the fast phase, and it can be within decreasing velocity, that is exponential velocity, that is the second one, B. Or it can be with an increasing velocity, which is the C. It's usually with the vestibular, you have an increasing velocity. Decreasing velocity is usually a gaze evoked. And when it occurs like a sharp upward and downward, then that becomes a jerk. When it's a smooth to and fro oscillations, it becomes a pendular nystagmus. This is the basics of the description of the waveforms. And depending on the oscillations, I said nystagmus pendular, as well as if it's quick to one side and then slow drift in another direction, this is known as a jerk nystagmus. Pendular form is usually no fast phase. Exponential increasing and decreasing velocity usually seen in the congenital nystagmus. Jerk, by convention, it's named after the fast phase. Suppose I have slow drift to the right with a fast corrective component to the left, then it's a left beating nystagmus. So coming to the differentiation between the jerk and the pendular nystagmus, the jerk nystagmus usually has the two phases, slow and the fast. Pendular usually has a equal velocity. It goes to and fro like a pendulum with normally usually the equal velocity. And then the direction of the nystagmus is described as the direction of the fast phase in a jerk. In particular, it can occur in any direction. And the jerks can be either horizontal or vertical or torsional or can be mixed, as will be seen. In pendulum, there is no direction, it's just in only one phase, and sometimes occasionally it can be like a seesaw. It's very interesting to note there are a lot of physiological nystagmus, and we will see how it is, because these occur when we experience certain, what should I say, symptoms when we are traveling or when we are into one of those rides. So we have a physiological endpoint nystagmus, per-rotational nystagmus, post-rotational nystagmus, which occurs after rotation, optokinetic nystagmus, optokinetic after nystagmus, and the vestibulo-ocular reflex or the caloric nystagmus. The first one is the physiological gaze-evoked nystagmus. All of us know that nystagmus occurs as the endpoint of the gaze. It's usually in the extreme gaze and lasts only for a few seconds. It's unsustained gaze-evoked nystagmus of short duration and low amplitude. In contrast, the primary position nystagmus can be sustained for over 20 seconds. Or if you have an asymmetric gaze-evoked nystagmus, then you should think of it as being pathological and no longer a physiological phenomenon. A sustained asymmetric gaze-evoked nystagmus is usually pathological. Per-rotational nystagmus is the nystagmus which occurs with sustained head rotation. If I do keep rotating my head, the fast phase is ipsilateral to the rotation and it usually has a horizontal jerk. Post-rotation is if I keep rotating the head and if I stop, then there is a nystagmus which rotates away from the head. And this almost gives a sensation as if you are in a rocking boat. You may have to steady yourself. This is post-rotational nystagmus after you end the rotation. We all know the optokinetic nystagmus, and from the physiology days itself, we know how to use the drums which are used for the optokinetic nystagmus. This is a physiological movement of the eye in response to a large moving visual field. This way usually is described as when we are in the train and looking out of the window of a moving train, you find the environment is moving. Actually, it's a train which is moving. And this can be demonstrated with the OK and drums. When you rotate the drums, you find the nystagmus coming on. Initial movement is a smooth pursuit movement. And that is followed by a contraversive second back to the primary gaze or direction of visual interest. Suppose you're rotating the drum clockwise and then the eyes shift and then they come back to the primary position. Asymmetry or abnormal can localize it to a parietal or parieto-occipital region. This optokinetic nystagmus. In contrast to that, you have an optokinetic after nystagmus. Here, the nystagmus is persisting for a few seconds after the stoppage of the visual stimulus. Rotate the drum, stop the drum. Even after that, for a few seconds, a nystagmus can persist. We can do it with both the vertical as well as the horizontal. Optokinetic nystagmus can be elicited by using these drums. So coming to the vestibulo-ocular reflex. This is a reflex which is predominantly controlled by the semicircular canals in the inner ear. And this is seen when a patient sees a fixed object, that's like the head impulse. Ask the patient to look at the object and move the head. I should stay back on the object. This is what we do with the head impulse test. Sometimes it does not happen. And the abnormality of this system can be very well demonstrated by the caloric test, where a nystagmus is elicited and the direction depends on whether you're stimulating the ear with a cold or a warm stimulus. And this you stimulate the semicircular canals with cold or warm water, about I think 50 ml plus or minus 7 degrees to the body temperature. Cold stimulus will turn the eye towards the side of stimulus. That's a slow phase followed by rapid nystagmus away. That is why it's known as cold opposite, warm same. In the warm stimulus, towards the side of the stimulus will be a slow phase and away from the stimulus will be, will turn slowly away with the rapid nystagmus towards the side of the stimulus. In cold, slow phase is towards the stimulus, fast phase is away. In warm, it is just the opposite. You can see in this picture, where is this? Is my, okay. This first one is with the cold. You can see the eye is looking towards the side, but the nystagmus is away. The slow phase is towards the side. Here it's a left ear stimulated, the slow phase towards the left side. Whereas with warm water, you find With stimulation on the right side, the eyes look to the left side, and stimulation on the left side, eyes look to the right side, so opposite direction. So we have seen physiological nystagmus, which can be gaze-evoked nystagmus, which can be vestibular or ocular nystagmus, which can be optokinetic nystagmus, can be a per-rotational, post-rotational nystagmus. And then now we come to pathological nystagmus. So this is an abnormal nystagmus arising from the central or the peripheral nervous system damage, especially to the vestibulo-oculocephalic or other cortical areas, which has a control over the oculomotor function. So sometimes it can be a spontaneous nystagmus. Sometimes we trigger a nystagmus. One of the triggered nystagmus is what we do in the positioning test for the benign paroxysmal positional vertigos. So first, let me take the visual causes. You have what is known as an infantile idiopathic nystagmus, otherwise known as an IIN. This is a motor nystagmus in contrast to the sensory nystagmus associated in children who have very low vision. Here the vision is generally normal, and this is seen in young patients, congenital, and this is also occurs bilateral. It is conjugate and in the horizontal plane, and that continues to occur whether the child is looking up or down. Very, very little variability is present. In contrast to spasmodic neurons, where it's got a lot of variability. And then this is a sensory nystagmus, where the nystagmus is due to a defective vision. We have seen patients with low vision will always have a nystagmus. It's usually horizontal nystagmus. Sometimes in children can be present the first 3 to 4 months. And later, once the vision and all improves, the nystagmus will go away. And this can be due to anatomic disorders of the eye that produce very poor visual sensory input. That can limit the visual development and may need evaluation when it occurs with aplasia of the optic nerve, with amaurosis, and iridia, achromatopsia, and albinism. These are the 5 A's. Very easy to remember the mnemonic in a sensory nystagmus of the children. Then one other condition is there, which is otherwise known as a latent nystagmus. This is known as a fusional maldevelopment nystagmus. This also occurs in a younger age group. It's a benign condition. This is also a conjugate horizontal nystagmus. And what is interesting is if you occlude one eye, there's nystagmus of the other eye occurring towards the side of the occlusion. And this occurs in both the eyes. So changes direction depending on whichever eye is occluded. You can see here, occluding one eye, it comes to this side. Again, it comes towards the occluded eye. So that is a little pathological. And here, spontaneous nystagmus in adults arising from the central nervous system or peripheral nervous system causes can be peripheral vestibular nystagmus or central vestibular nystagmus. What we have seen earlier was all disorders of the eye, usually in children, idiopathic infantile nystagmus. Then you have the sensory nystagmus, spasmodic neurons, and the latent nystagmus. Now I'm going into the pathological condition affecting the vestibular or the central or the peripheral vestibular system. Vestibular nystagmus, as already mentioned, is a linear waveform. It can be with an accelerating phase as shown in the second row, or it can be a decelerating phase, or it can be with linear velocity where it's something like a sawtooth. And you get spontaneous peripheral vestibular nystagmus when there is a difference in tone between the vestibular nerves and the labyrinth because of the end organ damage. That usually produces a strictly unidirectional nystagmus. Sometimes it can be horizontal torsional, vertical torsional, or horizontal vertical also can be there, depending on the direction in which it is present, and usually much more unilateral. Peripheral vestibular nystagmus usually is dampened on visual fixation. You ask them to look at an object, then the nystagmus is less. Unilateral vestibular hypofunction will produce a drift, slow phase towards a lesion side. Suppose if I have a problem in the right ear, the nystagmus will be a slow phase towards the right side with a fast component towards the opposite side or the intact side. And that is known as the Alexander's law, which states intensity is greatest when looking towards the intact side. Direction does not change with gaze, unlike the gaze-evoked nystagmus. It's the same direction, but does not change gaze. Only the change occurs in the speed. Surprisingly, bilateral vestibular hypofunction does not produce any nystagmus because there is no asymmetry in the imbalance in the vestibular system. That is vestibular. So we finished ophthalmological causes, vestibular. Now coming to the CNS causes. So that is known as the central forms of nystagmus. This occurs because there is some dysfunction in the connections between the central vestibular system and the neural integrators, which can be, the whole thing can be the cortex, the brainstem, the cerebellum, along with the vestibular nucleus and its connections, or the end organ also. This is not inhibited by visual fixation. In vestibular, usually it is inhibited. Here, it is not inhibited by visual fixation. It can be purely vertical or it can be torsional also. Here, this slide shows the difference between the central and the peripheral nystagmus. The central nystagmus, usually the other symptoms such as numbness, weakness, diplopia, dysarthria, something like a posterior circulation stroke. Whereas in the peripheral, maybe some symptoms associated with changes in the posture, some ear symptoms can be present. And dizziness, spinning sensation, diplopia are more in the central. Vertigo can be present in the ear, along with tinnitus, loss of balance. Duration is much more longer lasting in central, can be very episodic and acute onset in peripheral. The direction of the nystagmus is horizontal, can be upbeat, downbeat, or torsional. In peripheral, it's horizontal or horizontal torsional. Change in the gaze, this gaze evoked change in the direction of gaze present in the central. It is not so in the peripheral. And fixation is reduces the peripheral, whereas it produces no change in the central nystagmus. And head impulse test is normal in the usually in the central, and head impulse test corrective seconds are present in the peripheral nystagmus. This is how we differentiate between the central and the peripheral. So what is this gaze evoked nystagmus? After each eccentric gaze, the eyes move towards a primary position, followed by a second towards eccentric direction. Suppose I look to the left, then I look straight. And then what if I'm looking to the left and look to straight? First, you find that the eyes produce movement towards the right, and then there's a jerk which is corrected. That is known as a right jerk nystagmus. If I move to the left, it occurs on the left side. In the left, that's known as a left jerk nystagmus. This can occur on lateral gaze or up gaze, low gaze, etc. And here also it follows the Alexander's law, which states nystagmus increases in amplitude and frequency as the patient looks in the direction of the fast phase. If suppose my fast phase, if I'm looking to the right and my fast phase, the slow drift to the right followed by, slow drift to the left followed by fast drift to the right, then when I look to the right, there will be a more nystagmus that is known as the right gaze nystagmus. Here there is a problem in the neural integrator. Rebound nystagmus is, even after you stop this eccentric gaze holding, there can be a few jerks which are transient, last usually less than 30 seconds. And sometimes this is seen in the cerebellar disease. This is following the gaze evoked nystagmus. This is a rebound nystagmus. Prince nystagmus, this is a combination of central and peripheral nystagmus. Here the patient usually has rapid small amplitude nystagmus away from the side of lesion, usually seen in CP angle tumors more than 3.5 centimeters. I'm not going to the other features. Upbeat nystagmus, as the name suggests, this occurs when you are looking up. So purely vertical conjugate nystagmus. That is, both the eyes move towards the same direction. This slow drift of the eyes downwards corrected by a fast upward saccade. Patients may experience vertical oscillopsia. They may find everything moving up and down. Upbeat nystagmus is a slow downward movement corrected by a fast upward saccade. And with vertical oscillopsia, which may or may not be present, usually occurs in brainstem or anterior cerebellar vermis. Contrast to that, the downbeat nystagmus is just the opposite. The jerk begins with the upward drift of the eyes, corrected by a downward saccade, which is the fast phase. Slow up, fast down. And that is a downbeat nystagmus, enhanced by down and lateral gaze. If you look down and laterally, then the downbeat nystagmus is much more. Usually occurs in craniovertebral junction and cerebellar syndromes. And it can be occur isolated, or it can be present in the same combination also. You've seen the gaze evoke vertical, horizontal nystagmus. Now coming to the torsional nystagmus, here the eye intorts or extorts. There's a rotation of the eye around the globe. You have to differentiate this from pendular nystagmus with side-to-side movement of the globe. Here also both the eyes move in the same directions, conjugate and symmetric. Only torsional nystagmus without any horizontal or vertical component, think of brainstem. If it is torsional with a vertical component, that is a midbrain lesion. Only torsional, rotation of the eye, conjugate and symmetric, then that is brainstem. Suppose torsional with a vertical component, it's a midbrain lesion. So dissociate all these with conjugate nystagmus, that's both the eyes moving the same direction, same phase. Dissociated nystagmus, here what happens is, nystagmus is different or dissimilar in direction, extent or periodicity of the oscillations between the two eyes. You know what happens in INO? Ipsilateral to the MLF lesion, there's an impairment of adduction of the affected eye, the abducting eye showing nystagmus. Suppose I have a left INO, then my left adduction will be defective and right eye abducting eye will show nystagmus. So one eye is not having the nystagmus, other eye is having the nystagmus. That is known as a dissociated nystagmus, usually seen in INOs. You can see the right INO, the fine on left gaze, both the eyes move towards the left, whereas in right gaze, the right eye is inability to adduct, whereas the left eye is showing the nystagmus, though the video is not there. So that is a dissociated nystagmus. This is a disconjugate nystagmus. Earlier we were seeing upbeat nystagmus, downbeat nystagmus, gaze evoked nystagmus are all conjugate when both the eyes move in the same direction. Dissociated is one eye is moving, one eye is not moving, or there is a changes in speed. Disconjugate is the two eyes are moving in two different directions. Okay, oscillations can be in two different, it's like a seesaw. When one is going up, other is coming down. That's known as all of us know that's a seesaw nystagmus. Can be a pendular disconjugate movement of the eyes in which one eye elevates and intorts, whereas the other eye depresses and extorts. So it's one eye elevates and intorts, and other eye depresses and extorts. Hemi seesaw is when it's not just a rotational, it is like a jerk with a jerky form. That is known as a hemi seesaw. The interstitial nucleus of gel adjacent to the medial longitudinal fasciculus has been implicated in the seesaw nystagmus, usually seen in cellular, paracellular, and diencephalic lesions. Periodic alternating nystagmus. Here, it's a unidirectional jerk nystagmus. Here, it's also conjugate. It's not a disconjugate, it's a conjugate nystagmus. Jerks, you find a unilateral jerk nystagmus followed by a dampening or cessation of the nystagmus, followed by nystagmus in the opposite direction. Suppose first I have nystagmus, unidirectional jerk nystagmus towards the right, comes to the center, then I have a direction nystagmus towards the left. That is known as periodic alternating nystagmus. To one side, stop, and then to the opposite side. And this may be associated with head movements also, because the moving eyes tend to fixate on the object and to avoid the visual illusions. Usually, the lesions in the vestibulocerebellum can be combined with flocculus or paraflocculus. So I said, see, it moves to one side, comes down, moves to the other side. This is the periodic alternating nystagmus. Now, convergence retraction nystagmus. This is another disconjugate nystagmus. Is an intermittent jerky movement in which the eyeballs rhythmically move towards each other. Convergence. The two eyes are moving towards each other and then slowly return to the mid position before next movement. In retraction nystagmus, intermittent quick rotation of the eyeballs, retraction of the eyeballs goes away, then comes together. So they are occurring in two different directions. One is converging, both the eyes are looking down, other one is retraction. Usually occur in rostral midbrain lesions. These are all nystagmus which can be usually occurring spontaneously or in certain positions. Regard nystagmus is when we can produce a nystagmus. Normally, when you test for the benign positional vertigo, we can do certain positions, a place maneuver where we can induce a nystagmus. Then you have the head shaking nystagmus, head-induced nystagmus, like the heads. Then sound-induced nystagmus, valsalva-induced, pressure-induced, vibration-induced, hyperventilation-induced, and pursuit-induced nystagmus. So having said all that, what I'm going to tell in the next few slides is slightly different. When these eye movements are continuous with both torsional and vertical components of 1 to 3 hertz frequency, sometimes they are associated with movements of the pharynx, face, vocal cords, and other body parts, which can be very rhythmic and which is in the same frequency as the eye movements, and they can be present even during sleep. If this acquired pendular nystagmus has the involvement of other parts of the body, then it's known as oculopalatal myoclonus or the oculopalatal tremor when it involves the palate. So, okay, with acquired pendular nystagmus, we have 1 to 3 Hz, which has acquired torsional quality, which has also involvement of pharynx, face, vocal cords, etc., can be known as oculopalatal myoclonus or oculopalatal tremor. Voluntary nystagmus is one where the subjects can produce a nystagmus on convergence, and it can mimic an ocular flutter, usually very brief, lasting less than 30 seconds. Grading of the nystagmus is into 3 grades. Grade 1 is only present in the direction of the quick component. Second, looking straight. And third is when it's grade 3 is when it's present even when looking ahead and looking in the direction of the slow component also. Then there are other movements which may be mistaken for a nystagmus. One is the saccadic intrusions, which are the ocular flutter and the opsoclonus. The saccadic oscillations can be mistaken because they are very rapid movements, refixation eye movements without any slow phase. Contrast, nystagmus usually has a slow phase eye movement in certain situations, or in the pendular, it's not so fast. Ocular flutter has an intermittent burst of back-to-back saccades. Keeps on moving back to back without any interval between the saccades. It's something like the atrial flutter, remember that. Typically lasts for seconds at a time and is usually only in the horizontal direction, in contrast to opsoclonus, which can move in very many directions. This lack of interval between the saccades is what distinguishes this from a square wave jugs. In contrast, the opsoclonus also has back-to-back saccades, but it's multi-directional, chaotic movement, sometimes known as saccadomenis. Movements are usually higher amplitude, larger and longer lasting. Then this is another condition, ocular bobbing and dipping, sometimes mistaken for a nystagmus. Here, this is also conjugate eye movements. In bobbing, what happens is a fast downward movement followed by a slow drift back to the midline, similar to a fish bobbing in the water.